You can proceed, sir.
So can you move the next slide, please? Yeah. So basically in our clinical practice, we are dealing with the two type of the urothelial malignancy. Now, one is the low risk unifocal tumors. Tumor size is less than 2 centimeter in size. Low grade cytology. Low grade most importantly, the tumor which does not involve the muscle. And second most important biology in our practice, that is a high risk biology that has some sort of the obstructive symptoms like in form of the hydronephrosis. Tumor size is more than 2 centimeter in size. High grade urothelial biopsy, multifocal disease, and some other variant apart from the next. So in low risk category, we can move ahead with the kidney sparing approach with some sort of a local adjuvant therapy to prevent the recurrence rate. But in high risk populations, we need to address of the neoadjuvant or adjuvant. So that will help us to reduce the increase overall survival of the patient. Next.
Dr. Kaushal.
Yeah.
Actually, Dr. Asim here. I guess you are moving from chair, so your voice is not picking up by the receiver. So
Okay.
it's sometimes audible, sometimes not audible. So please
now
take care.
I am now I am
yeah, it's perfectly fine.
Yeah. So if anything, please let me know. If we consider all of the urothelial malignancy, then 5 to 10% of the tumors, they are the upper urothelial malignancy. Out of this, 60% they are the diagnosis, and 25% have the regional metastasis disease. Distal failure rate is also not common in this particular population. So now the most important questions, because 5 to 10% of the all urothelial malignancy. So can we extrapolate the results of the bladder cancer studies to this type of the tumors? Next. Because these are the anatomically, biologically, practically two distinct variants. Apart from that, next, there are some sort of the different genetic mutation has been documented in the patients who are having upper urothelial malignancy, and issues with the preoperative histopathology as well, because there is some obstructive symptoms that will lead to the reduction into the GFR that will also affect into the treatment protocol. Next. So now that is most important part of the discussion, the perioperative chemotherapy for urothelial carcinoma, urinary tract. One systematic review and meta-analysis of the 13, 11 for the adjuvant and 2 for the neoadjuvant, which include approximately 11 therapy was associated with case-specific survival rate.
I request you to keep the mic closer to your mouths because your voice is quite feeble.
Yeah, so available data suggests associated with the improved survival in patients with the upper tract urothelial cancers. Next slide. Yeah. So if we see the summary of the meta-analysis which evaluating the neoadjuvant and adjuvant chemotherapy, there are the retrospective as well as prospective data which shows that the additions of the any type of the therapy, either it's a neoadjuvant, that will associated with the better overall survival rate and better disease-free survival rate. Next. So now this is the two parts. One is the neoadjuvant chemotherapy. If we see the pool analysis, then it shows that the pathological complete response rate has been documented approximately 11%, and partial pathological response has been also documented 43%, both across the 14 studies. And if you see these studies analysis, then there is definite advantage of the overall survival rate as well as the case-specific survival rate. And according to the guidelines of study, it's labeled as a category based level 2 as a neoadjuvant therapy. If we move to the adjuvant therapy, then it shows the better overall survival rate. and better case specific survival rate. Along with that, also there is a disease-free survival has been documented with the adjuvant studies. Most of the studies, they are the retrospective, but there are the two prospective randomized studies have been there. So the adjuvant therapy has been labeled as a level 1 evidence. So if we see, the next slide, please. Yeah, so these are the some of the neoadjuvant trials for the urothelial tract carcinoma, and it into different drugs, which include the gemcitabine, cisplatin, gemcitabine, carboplatin, dose-dense MVAC. Along with that, there has been some studies which also include the immune therapy, durvalumab plus temolizumab and pembrolizumab. Next. And if we see, there is one phase 2 trials of the neoadjuvant systemic chemotherapy, followed by the surgery for the patient with high-grade upper urothelial carcinoma. In this, there are the two arms. In one, there is a dose-dense MVAC, and another one, there is a gemcitabine plus carboplatin. And in both the conditions, there is a significant improvement into the pathological complete response has been documented. So together, the result of this prospective trial support the use of the neoadjuvant chemotherapy into the patient who are eligible for the high-risk urothelial malignancy. Next. One POUT study is there, the adjuvant chemotherapy in upper urothelial carcinoma, that is a phase 3 open label randomized studies, and in which the post-surgery, the patient has been given to the gemcitabine and platin-based chemotherapy. And when the patient is not eligible for the cisplatin, the patient has been given carboplatin as the chemotherapy options. And if we see the study, then adjuvant platin-based chemotherapy should be considered as a new standard of the care after the surgery, because it has documented to increase the significantly disease-free survival rate as well as overall survival rate into the patient who are having locally advanced urothelial carcinoma. Next. Next. Yeah. So this is the a study. Most of the patient has received cisplatin, but the patient who are ineligible for the cisplatin due to creatinine clearance abnormality, they has been considered for the carboplatin. Next. And if we see the primary endpoint of the study, that is a disease-free survival, then if we see the curve, then there is a significant separation of the curve has been documented when the patient has been put in survival and the patient has been treated with the gemcitabine plus platin-based chemotherapy, with hazard ratio is quite significant, which support the adjuvant chemotherapy to increase the DFS into the patient population who are high risk for the recurrence. Next. And if we see the subgroup analysis, then if we see, then all populations of the study, either it's the node positive, node negative, gemcitabine plus cisplatin or gemcitabine plus carboplatin, positive or negative margin, all the populations, they are getting advantage into the overall survival and disease-free survival. Next. And if you see the secondary endpoint of the study, that is the MFS is also significantly metastatic free survival, that is also more documented into the patient who has been treated with the chemotherapy compared to the patient who has been treated with the surveillance. Next. And OS is also much better into the patient who has been treated with the chemotherapy compared to the surveillance, though it is a statistical insignificant. But theoretical, we can say that there is a separation of the curve has been documented in these two study. Next. So if you see the POUT studies analysis, then the benefit of the adjuvant chemotherapy on disease-free survival and metastatic-free survival was maintained with additional follow-up. There was a non-statistical significant improvement into the overall survival has been also documented. This updated analysis support the use of the platin-based adjuvant chemotherapy as a recommended standard of the care. 40% of the enrolled patients were cisplatin ineligible and they has been treated with the carboplatin, and approximate 21% of the patients has been also crossover to the carboplatin. So if the patient is ineligible for the cisplatin, we can use carboplatin as a treatment combinations along with the gemcitabine. Next. So here, cons and pros of the adjuvant versus neoadjuvant chemotherapy. If we use the adjuvant chemotherapy, it will give the accurate pathological staging, no delay to the surgery. We have randomized phase 3 data which support the use of the adjuvant chemotherapy. And if we use adjuvant chemotherapy, then then it will delay the chemotherapy because it should be given after the surgery. When we give the chemotherapy at that time, only one kidney, so we should consider the patients while treating with the cisplatin. Sometimes post-surgically, there is an issue of the tolerability is also there. And if we use a neoadjuvant chemotherapy, then it will treat the micrometastatic disease from the beginning, good tolerance and good renal function because we have two kidney at that moment. Assess the chemosensitivity, so we can use the chemo drugs post-operatively also if needed. And it's rely on the clinical stages and delay the surgery. These are the two negative points for the neoadjuvant chemotherapy. So we can say that either neoadjuvant or adjuvant chemotherapy, whatever it is, it should be the part of the treatments for the high risk, high grade urothelial upper urothelial tract malignancy. Next. Yeah, so sometimes we are using the prophylactic intravesical chemotherapy to prevent the bladder tumor after the nephrourectomy for the primary upper urinary tract urothelial carcinoma. And if we see the systemic review and meta-analysis, then it shows that the post-surgical intravesical chemotherapy will significantly decrease the risk of the bladder recurrence after the nephrourectomy for the primary urothelial upper cancers. Next. There is one study, Gemini, that is open label single arm phase 2 study, in which the intraoperative gemcitabine for intravesical installations in patients who have been treated with the radical nephrourectomy for upper urothelial tract carcinoma, which shows that there is an advantage for prevention of the bladder recurrence later on if we use the intravesical or intraoperatively gemcitabine chemotherapy. Next. We have documented study from the Lancet which shows that primary chemo ablation of the low grade urothelial carcinoma using UGN 101 mitomycin containing drug or thermal gel, which will also responsible for the prevention of the local recurrence when the patient tumor is low grade and locally related. Next. Some of the adjuvant studies are ongoing, which include the chemotherapy as well as immune therapy combinations, single agent immune therapy, immune plus immune therapy combinations. And we are expecting their result in positive direction within very short period of the time. So we can avoid the chemotherapy drugs in cisplatin ineligible patients to get maximum advantage into the high grade upper urothelial transversal cell carcinoma. Next.
My apologies, sir. You are left with 2 minutes to conclude your presentation.
Yeah, sure. I will do it. And according to the European guidelines, we have strong evidence to offer the post-operative systemic platinum-based chemotherapy to the patients with muscle-invasive urothelial carcinoma, and to deliver a post-operative single-dose bladder installation of the chemotherapy for the low-grade tumors to prevent the intravesical recurrent rate. Next. These are some of the ongoing studies for the upper urothelial malignancy. We are hoping the positive result also. Next. Next. Yeah. So these are some of the immune therapy based studies which are ongoing, and we are expecting the result within short period of time, which include the single agent immune therapy or immune therapy plus chemotherapy combinations. It does have good number of the patients, so we have some strong conclusion for the use of the adjuvant chemotherapy or immune therapy into the high risk, high grade urothelial malignancy. Next. Next, these are some of the local therapy which also shows the evidence of the positive result into the high risk urothelial malignancy for prevention of the recurrence. Next. So take home message from my discussion. We do have two type of the tumors, upper urothelial malignancy and lower urothelial malignancy. And among them, there is a high grade as well as the low grade with high risk and low risk populations. There are evidence too for the OS as well as the CSS benefit for the neoadjuvant chemotherapy. There is a level 1 evidence for the adjuvant chemotherapy for getting OS, CSS as well as DFS into the patient who has been treated with the surgery. There are some of the studies which include the immune therapy, single agent immune therapy plus immune therapy and immune therapy plus chemotherapy combinations, which will provide us better result compared to the ongoing on available studies results, which include the chemotherapy for the future. So my take-home message in short word, either we should give neoadjuvant chemotherapy, preferably if yes, and if we are not able to give the neoadjuvant chemotherapy in such population, then we should at least go for the adjuvant chemotherapy for such type of the patient for prevention of the recurrence as well as the overall survival. Thank you. Thank you.
Thank you, Dr. Kaushal Patel, for your nice presentation. And now I will